Let's jump right into the next best step decision logic for pediatric urology and genitourinary trauma. For Step 2CK, it's all about how you sort these patients. We're looking closely at age, their specific urine symptoms, volume status, and any trauma mechanisms to quickly identify the right diagnostic and treatment pathways.
The critical branch point begins the moment a neonate or child presents with abnormal urine output or urinary symptoms. You have to sort them immediately. Is it oliguria, a weak stream, daytime incontinence, nighttime-only enuresis, or maybe recurrent febrile UTIs? Pinning this down dictates everything that follows. So if you've got a neonate with oliguria, start with a targeted history and physical exam. Check for maternal nephrotoxin exposure, any family history of renal anomalies, and definitely assess their volume status. Then your next best step is going to be a renal and bladder ultrasound. You're looking to assess the number of kidneys, their shape, size, any vascular abnormalities, congenital defects, and, of course, obstruction.
When breaking down neonatal acute kidney injury, map it out into prerenal, intrinsic, and postrenal causes. Prerenal includes things like hypovolemia, cardiac disease, and sepsis. Intrinsic covers acute tubular necrosis, nephrotoxins, renal vein thrombosis, and cystic disease. And then postrenal, that's going to point you straight toward an obstructive uropathy.
Speaking of obstruction, posterior urethral valves are an obstructive uropathy seen in male infants that physically prevents bladder outflow. These patients present with a weak stream, straining, daytime and nighttime incontinence, recurrent UTIs, and significant bladder distension. Complications are severe. Think vesicoureteral reflux, hydronephrosis, renal scarring, and eventually CKD. Also, watch out for prenatal oligohydramnios in the history, since fetal urine contributes heavily to amniotic fluid volume.
Shifting gears to urenesis in a child who is age 5 or older. The absolute first step in your evaluation is always a urinalysis. You have to rule out secondary causes before you can even think about diagnosing primary urinary.
If it is primary nighttime-only enuresis, this implies delayed bladder maturation. There's often a family history, maybe increased nocturnal urine output, or just a low bladder capacity. The management here is stepwise. First, treat any comorbid constipation. Then limit evening fluids, implement timed voiding, try an enuresis alarm, and if needed, administer desmopressin.
But if you're dealing with secondary enuresis or any new daytime symptoms, that requires an immediate evaluation. You need to look for UTIs, diabetes mellitus, diabetes insipidus, obstructive sleep apnea, bladder dysfunction, constipation, CKD, or even psychological stress.
The algorithm for evaluating bladder dysfunction strictly separates nighttime from daytime symptoms. If that initial urinalysis is negative and the symptoms happen only at night, you manage it as nocturnal enuresis. But daytime symptoms, those require a deeper dive to evaluate for underlying structural or neurologic etiologies.
Be on high alert for red flags indicating a spinal cord anomaly. If you see neurologic deficits, like lower extremity weakness, or lumbosacral cutaneous abnormalities, like a hair tuft or a dimple, those mandate a spinal MRI to evaluate for spinal dysraphism.
Now, for the recurrent febrile UTI branch, especially in diapered infants, you must always obtain a sterile urine sample via straight catheterization for the urinalysis and culture. Clean catch is just too unreliable here. And keep in mind, infants often present really non-specifically, maybe just a fever, fussiness, or poor feeding.
For management by age, children between 2 and 24 months presenting with their first febrile UTI, as well as any child with recurrent febrile UTIs, absolutely require a renal and bladder ultrasound to check for anatomic abnormalities.
If you see recurrent febrile UTIs, that strongly suggests vesicoureteral reflux. Avoiding cystourethrogram is the definitive test here. It's indicated for those recurrent febrile UTIs, a first UTI if the patient is under 1 month old, infections caused by a non-E. coli organism, or if that initial ultrasound showed an anomaly. VUR is then graded from 1 to 5 based on the degree of dilation and tortuosity.
Mild VUR is generally managed with observation, bladder and bowel management, and occasionally prophylactic antibiotics, mainly because it often resolves spontaneously as the child grows. Higher grades, however, require prophylaxis and surgical intervention. A DMSA scan is often used to evaluate for the major complication here, which is renal scarring.
Let's look at isolated proteinuria.
This should always be followed up with repeat dipstick testing. If subsequent tests come back negative, you're dealing with transient proteinuria. This resolves on its own and is often just triggered by something like a fever or stress.
If the proteinuria persists, you'll want to evaluate for orthostatic proteinuria, which is actually really common in adolescents. It's mild, completely absent at night, and requires absolutely no treatment once you've confirmed the diagnosis.
Moving on to genitourinary trauma. You need to sort these patients based on their exact presentation. Are we seeing gross hematuria following blunt flank trauma, or is there blood specifically at the urethral meatus combined with an inability to void?
For hemodynamically stable patients with suspected renal trauma, the next best step is a contrast CT of the abdomen and pelvis. On the other hand, if you suspect a bladder injury, that needs to be evaluated with either a retrograde cystogram or a CT cystogram.
Here's a strict rule for the exam. Blood at the urethral meatus, a pelvic fracture, perineal ecchymosis, or difficulty voiding all heavily suggest a urethral injury. You must perform a retrograde urethrogram before you even consider placing a Foley catheter. Doing so blindly could easily convert a partial tear into a complete transection. When managing these, posterior urethral injuries typically require a suprapubic catheter with a delayed surgical repair. Anterior urethral injuries, however, are managed with earlier surgical interventions or early Foley placement.
Finally, postoperative urinary retention presents with low urine output, suprapubic pain, and noticeable bladder distension. The immediate treatment here is straightforward: indwelling or clean intermittent catheterization.